Hello, it's really nice to be here. It's really nice to be able to blend this and have people join online as well. So thank you very much for asking me to speak this afternoon. I have an element of imposter syndrome, having seen the big list of names that have been already and are to come. But I hope that this will be helpful to you in the room and also to those of you online. I started working in dermatology a couple of years after I qualified as a nurse in 1990. I got into dermatology by accident because I hurt my back. And back in 1990, we didn't have many options for people with chronic skin conditions apart from to admit them to hospital. And they weren't particularly ill, so they didn't need lifting up and down beds and things. And I have stayed within the specialty ever since and passionate about it. So scalp psoriasis was what Helen asked me to talk about. And so let's see what comes. So what I'm going to do in the next 20 minutes or so, I'm going to just talk a little bit about the terminology I'm going to use. We'll have a quick look at some of the guidelines because they're there not just for clinicians, but everybody. And it helps to, I think, set some expectations of what people should be provided with within consultation. So we'll have a quick look at those. And then we'll spend more time on topical therapies. And again, I'll talk about the terminology in a minute, so I'll tell you what I mean by that. And what happens when they're not sufficient. And also a little bit about the research. But I do want it to be interactive. So if anyone's got any burning questions going through, you can't see very well here because the lights are quite bright. So, but I will leave plenty of time at the end as well, and we can just go back through. I haven't got particularly whizzy, exciting slides, so it just be relatively straightforward and see where we go along with that. So, the kind of terminology I'm going to use, I am going to talk about patients and their carers. I'm a clinician, I see patients, and I'm going to get tongue-tied if I do anything otherwise. So, but I acknowledge that I am not an expert in this field because I don't have psoriasis, and every person online or in this room who has psoriasis is the expert in their skincare. We can give you tools as clinicians, but we can't use them. So I think that's important that although I'm going to talk about clinicians as the healthcare professionals, you may be involved with doctors, nurses, pharmacists, podiatrists, physicians associates. There could be a whole range of healthcare professionals. And my terminology for that group of people today is clinicians. I'm going to talk quite a lot about topical treatments. And by topical treatments, I mean creams, lotions, potions, all sorts of different formulations that are applied directly to the skin. And of course, we're talking about scalp, psoriasis, so applied directly to the scalp, acknowledging that there's often hair in the way as well. And when we talk, I'll give a few tips that people have given back to me as I've gone through my career about kind of negotiating how to get things in the right place on scalps and things like that. Just towards the end, I'm going to talk a little bit about systemic treatments. And by that, I mean either oral, so taken by mouth, or injectable medicines that go systemically into the body. And that's how I'm going to differentiate topical and systemic, but I haven't got a huge amount on that. And there's just a little bit at the end about biologics, and I think you've probably heard about that kind of treatment a little bit. And they're treatments that they're called biologics because they originate in living cells, and then they're genetically modified, genetically changed. And they snip tiny parts of these very specific parts of the immune inflammation pathway. So what guidelines do we as clinicians have? The 2012 was a massive year for me because the psoriasis guidelines that were produced by NICE changed my practice. The National Institute of Health and Care Excellence. It was 10 years ago now. Can you believe 2012 was 10 years ago? And there were certain elements of that I had never formalized into my consultations. But why am I talking about that? Because actually it standardizes. It says what all clinicians should be able to offer within a consultation, and therefore what everybody who goes to see a clinician about their psoriasis, whatever part of them it is, should have as standard. I'm also going to mention ever so briefly the Primary Care Dermatology Society guidelines, so that's what they're on there for. One of the things that I think is really crucial is around assessment, because we can't recommend treatment if we haven't provided you with a good assessment. And that's where the NICE guidelines are really helpful, because they indicate that at every appointment that somebody with psoriasis, wherever that psoriasis is on them, and however severe or mild, and I use that spectrum of terms in a very loose way, because what might appear mild to me may well not be mild to somebody who sat in front of me. And that's really, really important. And I think that's why I've got this slide up, actually, because the NICE guidelines say that a clinician should make an assessment of severity, but they also say we should ask you how you would rate your psoriasis. And I think that's very important. And usually it's a global scale. There are all sorts of clever scoring tools. It's not particularly helpful to have an area and severity index score if your psoriasis is in one main place, because that's not a huge area of your body. And of course, many people with scalp psoriasis have psoriasis in other areas, and quite a few, it manifests in a limited location on the scalp. And what somebody else should also, or the clinician should also ask at every consultation is about the impact. What's the impact of your psoriasis today on your physical, your psychological, and your social well-being? So we have kind of scoring tools. Many of you may well have filled out a Dermatology Life Quality Index tool in paper, and some fantastic departments can now do them on iPads and things like that. You may be sent a link to do it beforehand and all the rest of it. And that gives us an indication as clinicians of the impact of your psoriasis on your quality of life, but it isn't going to tell us anything particularly about how it impacts on you psychologically or socially. So we should be asking those questions as well. And we also should be asking about associated conditions. NICE calls them comorbidities, arthritis. We know there's a big link there. And also heart and circulatory system questions. There are some links across there with the inflammation, and psoriasis is a full body condition. It's a systemic condition. So we need to be asking about those as well. And high cholesterol comes in there, high blood pressure as well. And interestingly, here's where NICE is also quite helpful, because it gives quite clear indications of when primary care clinicians should be referring into secondary care, into specialist settings. And that is if people are not responding well on topical treatments, or there is a major impact on their physical, psychological, or social well-being. Now, having worked in specialist setting for very, very many years, one of the key frustrations that I've heard time and time again from people with psoriasis is that they can't get through to specialist settings. They have to get referred, and that can be very difficult. But this is what our evidence-based guidelines tell us. Right, let's go on to topical treatments then. Now, I have to say, I have no magic wand. I wish I did, but we've got a set of treatments that the topical treatments, apart from the development of the vitamin D analogues, we haven't moved on very much in the 32 years I've worked in dermatology, because many of them are still based on TARs, and they work, or they may work, but they smell, they're messy, they're quite difficult to use sometimes. So the first line treatment, and many people will have been given topical corticosteroids to treat their psoriasis. Steroids come with a warning. They tell you shouldn't use them. If you read the patient information leaflet, it will say don't use it for more than 7 days. And yet the guidelines and the clinicians will be telling you to use them for way longer than that. And I think it's important to understand we actually don't know how long continuously they can be used for. But it is way longer than a week before you're going to see potential side effects, unless you're using very strong steroids on very thin areas of skin. Because different parts of the body have different thicknesses of skin. So palms and soles, lots of layers of cells within the top layer of the skin. So you've got to go strong to get it down through to the area where it's going to inflame. Face, eyelids, genital skin, thinnest skin. So the stronger steroids will go in much quicker, you'll absorb much more, and there's potential for more damage there. And so, although I can't say you can use them for 3 weeks, you'll be fine, you can use them for 5 weeks, you'll be fine, we've got to apply the principles that we've got to match the strength of steroid we're advising to the thickness of skin. Scalp, it's fairly standard skin really, but you've got to get through the hair so that you're not, unless of course you're follicularly challenged, and then you will go straight onto the scalp. But for many people, they're not going to absorb as much product, they're not going to get the product where you need to get it as easily because hair gets in the way. But steroids still tend to be the mainstay of treatment, or if we use combination of topical treatments for scalp psoriasis, which we tend to advise, they're part of that regime as well. So the guidelines say the potent ones, the stronger ones, are safe on the scalp once daily for 4 weeks. Many people will be using them for longer and not see potential skin thinning side effects. And for the very potent, so potent in the potent group, the brands you will be looking at are Betnovate, betamethasone, Elicon, mometasone. Potent, the most common one is Dermovate, which is clobetasol, as opposed to clobetasone, which is a moderate. It doesn't help everyone, does it? It's all a bit confusing. And so sometimes actually when I'm putting a moderate potent steroid for somewhere else on the body and a very potent one for a scalp, I do it by brand. I will prescribe by brand. So I know that you're getting a product that says Dermovate, even though it might cost the NHS a bit more, and one called Umivate, and there will be no 2-letter difference, clobetasone, clobetasol. The formulations of topical steroids, we have got some more actually, we've got more options here. So they come as shampoos, so you can put it on, leave it on, rinse it off. The topical steroids come as scalp applications. Now I'm not going to say who's used those, but actually a lot of people come back to me and they tell me they sting. They're alcohol-based, a large number of them. They're quite thin, so going through hair and not making hair greasy is a definite advantage. But actually, if you've got cracked sore scalp, an alcohol-based product is going to be eye-wateringly discomfort. And one of the products in terms of topical steroids going on the scalp that I prescribe an awful lot of is a gel. It's a water-based gel. Think old-fashioned hair gel, anyone who's kind of my age and above. And I think there's only one product on the market, and it's gel. It's a potent steroid, and I do recommend that quite a lot, prescribe it a lot, people. And I'll ask somebody when they come back, how did you get on? I didn't like it, left my hair a bit greasy. Shall we try a scalp application? It might sting, but have a go. Or usually it's the other way around. Somebody else has prescribed me this, it's really uncomfortable. The combination of treatment with vitamin D analog calcipotriol, originally on the market as Dovobet. It has gone generic, I think now, but many of you will be familiar with that as Dovobet. It's first, that's why I put the primary care dermatology society guidelines up there because it's actually higher up the rankings there. And it's a combined product, so we're not giving you several different ones to use. So it's a very useful one to have. It's quite effective for some people. Other people, it stings. The vitamin D analogues can be itchy. And this is personalised care. It's what's effective for somebody trying it. Can give the range of products, but unless it's comfortable and practical, and I use that term in enormous inverted commas there, for somebody to use, then it's not going to come beyond one treatment. But scalp psoriasis tends to be pretty scaly. Scales don't flake off because often they've got hair in the way. So they tend to adhere to the hairs and stay stuck where they are. And so for any treatment going on to scalp psoriasis to be effective, we need to be dealing with the scale first, because they're not going to get to where they need to go otherwise. And the most effective product there is a combination of coconut oil, tar, and salicylic acid. I think the brand that's most frequent, most likely to have these days is something called Sebco. It smells of tar. So if you don't like the smell of tar, it's a big problem. If the person you share a house with, a bed with, doesn't like the smell of tar, it's a huge challenge. And ideally, to work as it's most effective, it does work best if it's left on for a period of about 8 hours, so it works quite well overnight. But I do get that many people wouldn't want to sleep in a tar smelly product that's greasy and is likely to stain pillows and all the rest of it. So I do suggest that people have a go unless they're really uncomfortable with that. Put a towel over your pillow because it's usually thick enough to stop anything going through. Put a shower cap on, but they're not awful to sleep in. Since COVID, I haven't been to many hotels. I think I've been to one, and they don't do the free little plastic shower caps anymore because we don't like single-use plastic, and I absolutely get that. But kind of regular shower caps are really quite thick and not very comfortable to lie on there as well. So one of my tips would have been save up a few shower caps from hotels, but that's a bit more challenging these days. So see if anyone's got any snuck away anywhere there. But actually it does work reasonably well if you leave it on for a couple of hours. So I sometimes suggest if people can get it on around tea time and then wash it off before they go to bed, that can be effective then in part of the cycle. I've talked about tar. It goes on the next page. So, let's go back to that. So I think perhaps the cycle that we see as most effective is a combination of 3 products, because you need to loosen the scale, you need then to wash it off, wash the coconut, tar and salicylic acid preparation off. And we usually would recommend a tar-based shampoo, but can leave residual smell in hair of tar as well. And there's a benzalkonium shampoo that doesn't smell of tar that can be quite helpful. And then put the topical steroid on after you've washed your hair, because you've lifted the scale. Picking isn't brilliant because you can cause damage. So loosening and lifting is much more helpful than really picking. And then having a steroid-based preparation on, and at least it's a bit cleaner and it doesn't smell. But somewhere along the line, if you've got hair like mine, you've got to dry it because you don't want to go to bed with dripping wet hair, and you've got a lot of juggling balls in the air. I realise that. I had a little look at what was licensed out of all those lists for children. So any prescription medicine in the UK carries a license, product license, and it's based usually on the research the pharma company has done to develop the product there. And the Dovabet is not licensed for children under 12, but we still often recommend things off license. Now, you should be told by your clinicians, if we're recommending an off-license product, we should be saying to you, it's actually outside its licensed indication, but in our opinion, it's probably the safest next option. We would use lower strength steroid for children as well. And I've mentioned the mess, the smell, it's a real challenge. And I don't give out topical treatments to treat scalp psoriasis lightly. The group of treatments we've got to treat scalp psoriasis are mainly topical. We'll have a look at what happens when topicals aren't helping in a minute. But the products are mostly topicals. And I say I don't do it lightly because I realize there's a huge burden for somebody to be able to do this. Often if somebody can use the Sebco for a few days to get the scale off, they then manage, patients come back and tell me just once a week or twice a week, keeps that scale at bay. And so although it's an initially arduous task, and I suggest try and pick a few days when we're fit with work and life and all the rest of it, actually, once that initial cycle's over, for many people, just once a week or twice a week will keep the scale down enough for the cleaner topicals to be helpful there. And people come back and apologize for not using treatments. And I say, it's fine, that's okay, because actually it's got to be treating your skin when you want to treat it, not when I tell you to. There's no point in that at all. And so it's about doing what's right for you when you need it, when you can fit it in. Now, actually, you probably don't want to take all of these things away on holiday with you. And so that's fine. Take what you need to manage a flare in case you end up in trouble, but don't come back and apologize. I don't want anyone to feel they ever have to apologize to a clinician for not using a treatment, because it's actually what you need to do when you need to do it is important. I've no idea how I'm doing for time. Oh, okay. Right. So what about when topicals aren't helping? So specialist settings are usually hospital outpatient departments, but at the moment I work in an intermediate care department, so it's a community dermatology team, so you still have to be referred in by a GP. And there are some specific clauses within the NICE guidelines actually, so it is quite helpful to think about when to step up to systemics for scalp psoriasis. Now, if you have psoriasis on other areas of your body as well, so you've got a wider coverage, you may well have the opportunity or be invited to take oral or injectable treatments earlier. But if it's a restricted area to the scalp, then you're never going to meet a psoriasis area and severity index score of 10 when the area is at such a small. But there is indication in the guidelines that if you're not controlling it with topicals, and there's significant impact on well-being, when it's localized, functional impairment, what an unhelpful term really, or high levels of distress. And the suggested medicines are methotrexate, cyclosporin, and acitretin. 3 treatments that many of you may have heard of or may not have heard of. They work, the first 2 by settling inflammation down, and the third one, acitretin, is a vitamin A derivative, and there's a whole cohort of people who can't take that if they're female and in childbearing years. But they may be helpful for scalp psoriasis, and there is an option to consider them there. So I did do a quick literature search. I do work at university, and I thought that might be quite interesting to see what's up and coming, what's being published in journals, specifically around scalp psoriasis. There are studies identifying that targeted therapies, they snip tiny bits of the inflammation pathway. And the cytokines, the inflammatory chemicals there, often IL is interleukin, and there are a huge number of them. So the 3 I have trouble with these names. Secukinumab, Izacukinumab, and brodalumab are IL-17. So that's the particular cytokine, the inflammatory thing that they kind of snip that little pathway for. And what the research indicates is that you get better control quicker with that group. But the IL-23s, they're on the screen, I'm not going to say them. They are also effective, but not as quickly. And so if you drew them on a graph, you get to the same point, but one will go up more quickly and one will go up more slowly. But of course, we've got limitations on costs. We've got clinical commissioning groups across the country who have different criteria. So there is still a postcode lottery, and that is so frustrating that you live in a particular area, your CCG may fund you to get there quicker than if you do in another area. There is actually also a little bit of evidence that some localized phototherapy works. And I have worked in a department, not for quite a long time, where we had a soricomb we used to lend out. So it was a little UV handheld thing that was used over the scalp. So that's kind of summed up really what we've got available to offer. A few tips along the way in how to perhaps minimize disruption, what to be asking for in terms of preparations as well. So if you are given something that stings so uncomfortably, you're not going to be able to use it. I mean, of course, you can use ointments and creams on your scalp as well. And for some people, particularly if you've got very short hair, they're going to absorb and they're going to be very helpful, but not always. So I wonder, therefore, has anyone got any comments or questions?